Hello, my name is Julia Heberle and I am one of the Senior Managers with Activity-Based Management at New South Wales Health. I'm a Health Information Manager by trade and I'm currently undertaking a PhD in Accounting through the Business School at the University of Technology, Sydney. When I was first introduced to patient costing in the mid-1990s, I had no idea it would result in a most interesting career, although referring to myself as a coster has always sounded a bit awkward. There are a few of us in New South Wales and in other jurisdictions that have been around for much of the adventure, and the recent submission of the 25th NHCDC is a remarkable achievement and one that should be celebrated. Extracting data to load into the early costing systems, I started with Cosmos, was not always easy. The amazing expansion of corporate and clinical information systems over the last decade or so in particular has enabled our costing efforts to mature from a top-down cost modelling approach to a bottom-up clinical costing that allocates cost to millions of intermediate products. This allows us to build detailed patient journeys, develop funding models, investigate variation, and inform management decisions. Sometimes the costing process is made more difficult when information systems are upgraded or a key person leaves the organisation. Despite these upheavals, however, after 25 years, there is an element of routine associated with the costing process. Until COVID, that is. The COVID-19 pandemic has resulted in significant upheaval and distress in our communities, hospitals, economies, and tragically for some of us, in our families. The text I received from my boss on the 11th of March 2020 at 5:27 p.m. was a bit of a, oh wait, what moment? And it set off a series of patient costing innovations that would have never happened in normal times. First, we suspended our 6-month costing submission. In New South Wales, our LHDs submit a July to December costing and then a July to June costing. Leveraging work that had been piloted the previous year, we immediately implemented a monthly cost modelling submission process, primarily to ascertain if the NWOW and the NEP was appropriate for our COVID-19 activity that we were expecting in our hospitals, and to inform internal discussions as to whether or not a quarterly actual cost data submission, as outlined in the NPCR, would be in New South Wales' interests. Our awesome costing workforce pivoted to submit 7 monthly year-to-date cost submissions, as shown in the table. The reporting requirements of the NPCR resulted in some general ledger practices that made costing more difficult. In some instances, there were centralised cost centres to facilitate NPCR reporting. This, however, sometimes broke the link between the expense and the intermediate product. The additional ICT cost package is a good example where it was sometimes difficult to identify whether the additional ICT cost related to the reconfiguration of wards, setting up COVID clinics, or related to the virtual general outpatient clinics that seemed to appear overnight. This information was important to ensure that we were allocating the right pool of expense to the right pool of activity. PPE is another example where this happened, which, given the importance of PPE in a pandemic and the significant additional cost, was something that caused us to think more deeply about cost allocation. For both these examples and others, we had many more discussions with our colleagues in finance and operations than normal to guide and develop the allocation logics. In other instances, our staff were redeployed to do COVID-19 activities, but their salaries or wages continued to be posted in the home cost centre because the business manager did not want them to think their cost centre was favourable. The interchangeable use of terms like costing and funding and budgeting suggests that there may be some people, including some senior people, who use these words without a lot of thought. To me, this is a bit like when someone says they need something when really they actually just want something. Costing, funding, budgeting are 3 very different constructs, and we need to keep calling this out. When the expected influx of COVID-19 patients did not happen and our hospitals were very quiet, we started to notice the impact on the cost model results in the April 2020 year-to-date submission. At this point, we started to have internal discussions about how to manage the decrease in activity, given we use volume-based cost allocation methods. Over the last few years, New South Wales has refined the cost allocation logic in operating theatres to separately identify and allocate the costs of unutilised theatre sessions for each case. This previous work made it much easier for us to understand the importance of ensuring the cost of unutilised capacity was held within the COVID period in round 24. So we created a costing period for intermediate products in the July 2019 to March 2020 period, which we called round 24.3, and a second costing period for intermediate products in the April to June 2020 period, which we called round 24.4. After both were run, a stitching process produced a consolidated report in the costing system to enable a single submission for the full year. This required a lot of work on the costing ledgers to identify any expenses in one costing period that should be included in the other costing period or distributed across the two periods. The effort was worth it though, as is shown in this little chart. In round 24.3 for this particular ICU, the cost per hour was $213. In round 24.4, the cost per hour increased by $69 per hour to $282. The cost volume variance analysis indicates a cost-related decrease of $9 per hour, but a decrease in the ICU hours resulted in a volume-related increase of $78 per hour. In this example, the volume-based cost allocation method results in a 32% increase in cost per hour between round 24.3 and round 24.4. And this change in hourly cost is driven by the change in volume. In round 25, the challenges were a little bit different. Activity returned and was fairly constant. There was, however, considerable expense reported under the various state public health payment packages through the MPCR. Our concern was that some of these expenses reflected new operating cost structures that will persist long after the MPCR is ceased. We wanted to ensure that these costs were allocated in ways that would enable us to either include or exclude them from our cost analysis. We went through each of the sub-packages and identified which ones were likely to reflect costs that would continue in the post-NPCR BAU environment. Expense in these packages was then allocated as direct costs. The little table illustrates a few that we believed represented a new BAU, such as the additional cleaning, enhanced security and ED's concierge, and those that did not, accommodation for health workers and contact tracing. This again required a huge effort to develop, test and document cost allocation logics and then implement them for round 25. Round 24 and 25 required lots of innovative thinking and confidence to have different ideas. There are three key things that I think have emerged in relation to patient costing during the COVID-19 pandemic. The first is the limitations of the cost allocation method typically used. Despite the bottom-up clinical costing approach, the cost allocation method used is a two-stage reciprocal volume-based allocation. It is not an activity-based cost method, despite what we might call it. From a technical accounting perspective, an ABC approach allows us to distinguish between the costs of available resources and the cost of the resources that have been consumed or utilised. The terminology here is very important and we have to be careful. One of the areas where I think we need to start fleshing this out a bit more is in relation to emergency and elective patient activity. In many of the larger hospitals, they have operating suites that are separate for emergency and elective cases to provide capacity for timely emergency surgery that does not impact on elective surgery programs. In fact, the theatre utilisation KPIs only include elective surgery sessions. There is an operational differentiation between emergency and elective sessions. If we do not separate out the costs of available and utilised resources in our theatre costing, it is possible we are understating the resources required for emergency surgery. This will obviously impact those hospitals that have significant emergency surgical caseloads. We may also need to think about the unplanned medical activity that is the subject of proposed hospital avoidance strategy funding model developments. Even if the strategies are hugely successful, and let's hope they are, we are still going to require some capacity for emergency cases in our hospitals. As a result, emergency cases may become more expensive if activity is reduced without an associated reduction in the significant fixed costs in, for example, emergency departments, wards, and medical imaging departments. As we found in our last few months of round 24, having the capacity to provide patient care can almost cost as much as actually providing the care. The second thought is in relation to our general understanding of what cost actually is. I continue to be amazed that when I meet with colleagues to talk about identifying the cost of a particular service or an intermediate product, their first statement is something like, well, my budget is. We have a deeply embedded budget control mentality in health. I would argue we have a limited cost control consciousness. Here again, the words are very important. I think it has been interesting to watch the definition of additional costs be reduced to become additional costs that would attract additional funding under the MPCR. I think if we are going to be successful in reducing the fiscal pressures associated with public hospital services, we need to be approaching this from a cost challenge as opposed to a budget challenge. Theoretically, we will get to the same place, but a cost management approach is likely to result in very different discussions than a budget management approach. And this leads me to my third and final point. I suspect the Delta and the Omicron COVID-19 variants will require us to think differently again for round 26 NHCDC submission. Outpatient costing, the NHCDC has evolved from the requirement to develop case mix classifications and funding models. Maybe the cost information is not structured and reported in a way that really facilitates cost analysis. We've come a long way in the last 25 years, but I wonder if we need to channel the innovative drive of the early costers and examine fixed and variable costs, the costs of both available and utilised capacity, separate out controllable and non-controllable costs. Thank you so very much for your time. I hope this short presentation has triggered some thoughts about how we can continue to refine patient costing. Take care and stay safe.